Welcome back to the Deep Dive. If you are preparing to step onto the wards as a junior doctor, or maybe you're navigating the really complex scenarios tested in the MSRA SJT, this deep dive is tailored specifically for you.
It really is. We're not just going to read the rules today.
No, we're going to try and understand the underlying safety algorithms of professional conduct.
Exactly. Today, we're focused squarely on that high-stakes world of clinical team leadership and, I suppose, professional safety. We're drilling down into how to lead when you might only be a junior member of the team.
And that's a huge one.
It is. And also how to delegate tasks effectively and safely, manage conflict in real time, and crucially, how to own team outcomes. All of this is anchored in the GMC guidelines.
Good medical practice, leadership and management, all the big ones.
Yep, those are the key documents.
So that's the mission. We've taken all that essential guidance, the GMC duties, the common SJT pitfalls, all the structured mnemonics, and we've tried to synthesize them.
Think of this as a way to translate those broad ethical duties into high-scoring, real-world safe actions.
Right. We need to internalize the core frameworks, things like SBAR, AC, leader, because they protect both the patient and, frankly, your professional license. So let's unpack the fundamentals of structured safety.
Let's do it.
So we're starting with what the sources consistently identify as the 3 non-negotiable pillars of safety. This applies in any clinical scenario.
Any at all.
Structured communication, clear ownership, and traceable documentation. So you step onto a ward, it's a high-pressure moment. What's the one overarching truth you have to hold on to?
The core truth is that safety in these complex, high-stakes environments is protected by clarity, not charisma.
I like that. Clarity, not charisma.
It's so important. You don't need to be the most senior or the loudest or even the most experienced person in the room to lead safely.
You just need to be the clearest.
Exactly. The clearest communicator, the most structured delegator, and the most diligent documenter. Every single safe decision, every successful transfer of care, it all relies on eliminating ambiguity.
So that means clear communication.
Named owners for every single task. And documented outcomes that you can trace later on. It has to be traceable.
When we think about the cognitive load on junior doctors, especially in the NHS, clarity is often the first casualty of pressure, isn't it?
It is. It really is.
So why does the GMC prioritize this structure so heavily? I mean, not just as a good idea, but as a professional duty.
Because it's literally written into your contract with the patient. GMC Domain 3 explicitly demands effective teamwork and clear communication.
So the structure is the safety net.
It's the system safety mechanism. If you look at every major incident review, whether it's in an SJT scenario or, a real-life patient safety incident, the vast majority point to a failure of communication.
Or ownership.
Or ownership, precisely. The SJT rewards options that use structure, SBAR, checklists, visible timeframes, over-improvisation, or what we sometimes call lone heroics.
Ah, the lone hero, trying to do everything yourself.
Right. If you try to manage a crashing patient all by yourself, or if you leave a critical task hanging with a vague instruction like someone will do it.
Yeah, that's a classic.
You're just creating ambiguity. And that ambiguity is the single biggest cause of delay, omission, and at the end of the day, patient harm.
Speaking of structure, let's talk about SBR. It's pitched as the universal language of safety.
It is.
But it's not just for handover, is it? We are talking about using SBR situation, background assessment request for literally any referral, any escalation, any task delegation.
For everything. That's absolutely essential to grasp. SBR is powerful because it forces you, the communicator, to filter out all the noise, be concise, and provide the necessary context for the recipient to act immediately.
It stops that 5-minute rambling call that starts with their entire life story.
It does. The one that finally gets to the point right at the end. SBR cuts through that.
Okay, so here's where the SJT seems to focus its scoring. The assessment and the request. Junior doctors are generally pretty good at this situation. Mrs. Jones is unwell, and the background.
Yeah, the story part is usually fine.
But the A and the R can be a bit weak. So how do we strengthen that assessment?
The assessment, the A, is where you define the urgency and your professional judgment. It's not just about listing the new WS score.
Right.
It's about linking that score to a clinical pathway. So, for example, instead of just saying her new W is 5, you'd say something like, her new Ws is 5, and I assess this as systemic inflammatory response syndrome, SIRS, that requires a sepsis 6 bundle start within the hour.
Ah, so you've shown you understand the implication.
Precisely. You've demonstrated understanding and linked the data to a time-critical protocol. You've gone from just presenting data to actual clinical analysis.
And then the R, the request. This is the crucial, clear ask that often gets you the highest score.
It is. It forces the recipient to act within a defined parameter. The SJT consistently rewards crisp SBAR referrals that have a clear ask and a time frame.
As opposed to the low-scoring answers like, can you review this patient when you are free?
That's the one. That's the trap. If you're calling a senior for a deteriorating patient, the R has to be, I need you to attend the ward within 10 minutes to assess and advise on moving this patient to HDU.
So you've defined the action, the urgency, and the resource.
You've left no room for interpretation.
Let's focus on the language of safety for a second.
Yeah.
Let's say we are escalating a highly specialized risk, like a potential stroke. Give us a model phrase that sticks.
Okay, a good example is escalating a suspected aspiration risk to speech and language therapy, or SALT. You wouldn't just say SALT needed some time.
Right.
The model phrase would be something like, SBAR to SALT. Urgent review. The 78-year-old stroke patient, admitted today, has a confirmed swallow screen failure and is coughing on their own saliva. Please assess swallow immediately and advise NBM status and fluid consistency urgently.
So you've named the recipient, salty, you've made it time-critical immediately, and the outcome is measurable.
Exactly. Advise on NBM and consistency. You've made it impossible for that request to be vague or pushed to the bottom of the list.
And this connects that clear communication straight to accountability.
It does. The GMC expects doctors to accept responsibility for decisions, for escalation, for learning, and this responsibility, it's retained even if you delegate the task. You are still responsible for the overall plan.
Okay, so this is the classic high-stakes pitfall. I delegate a stat blood test to a colleague, they get busy, they forget, the critical result is missed, and the patient deteriorates. Who is ultimately responsible?
You are. The person leading that plan retains the overall responsibility for the system being safe and for the follow-through.
That's a tough one to swallow sometimes.
It is, but it's why frameworks must make accountability explicit before something goes wrong. We have to use these high-yield action frameworks like Own the Outcome or PAC-CTTC.
Okay, let's detail PAC-CTTC because this sounds like it turns a to-do list into a proper, accountable plan.
It does. PAC-CTTC is about ensuring that continuity and traceable ownership. You start by setting the purposation. Purpose defining the goals and the risks right up front, so everyone has a shared mental model.
So for our crashing patient, the purpose is stabilize and transfer to HDU.
Exactly. Then you move to actions and the really key shift. Champions.
Champions, not just tasks.
Precisely. This is where you move from tasks to named, owned actions. It's the highest yield step. If you just say the patient needs bloods, that's a task hanging in the air.
Someone will do it.
Hopefully. But if you use PAC-CTTC, you say, Jamie, you are the champion for blood gases and lactate, due by 10.15. If the lactate's over 4.0, call me immediately.
So you've linked the champion to the timeline.
Ensured the flow of information through documentation and enforced traction through review and learning, it closes all the loops.
Let's run a quick scenario. It's 9 a.m., post-operative patient, suddenly hypotensive, stats are dropping. I'm the FY2 on the ward. How do I apply PAC-CTTC right there and then?
Okay. First, you establish the purpose. Identify and treat the cause of shock. Then you assign champions explicitly. Nurse in charge, you are the champion for calling the surgical registrar via SBAR and requesting blood products. Anesthetist, you are the champion for airway and access. I am the champion for fluids, sepsis screen, and labs.
And the timeline is immediate.
Within the next 5 minutes. By naming the owner for every critical function, you eliminate that risk of duplication or worse, omission. If Jamie misses the blood gases, the system immediately flags a failure point.
And you know who to go to for an update. You're not just asking what task was missed.
Exactly. It's who owns this action. It's a fundamental shift.
And what about escalation? We mentioned junior doctors can be reluctant to bother seniors.
Oh, massively. But the GMC views delayed escalation as unsafe practice. It's a critical red flag.
So escalating early is...
What? It's creating capacity. It's not failing. If the patient has an NUWS2 of 9, or if you feel your team just cannot cope, you must call your senior, the site manager, or the bed manager immediately.
It's a mandated action.
It is. When capacity thresholds are met, you escalate. Waiting or thinking you can fix it alone, that's what leads directly to unsafe delay and professional risk. You are calling for system support.
Okay, let's hit the trap answers tied to this. We mentioned the lone hero mentality. Why does the GMC framework, especially with PSIRF, penalize trying to do all the work yourself?
Because PSIRF, the Patient Safety Incident Response Framework, demands we look at systems, not just individuals. I'll do everything myself, scores poorly for, well, three main reasons.
For what?
One, it creates bottlenecks and exhaustion. Two, it removes the safety net of independent checks. And three, it violates the principle of safe delegation, which is vital for timely care.
And after an incident,
Huh.
what's the trap answer then?
The trap is blame the FY1 publicly. It completely destroys the team culture, it violates the just culture principles in PSIRF, and it prevents any real organizational learning.
So the correct action is always to stabilize the patient first.
Always. Stabilize the patient, acknowledge the event, set an owned plan, and then link the error back to governance. You have to ask why the system allowed the failure, not just who failed.
This moves us seamlessly into Section 2. Safe task allocation. This is where accountability meets the practical execution of managing tasks.
Right, and delegation is so often seen by juniors as just, offloading work.
But the safety perspective is much more rigorous.
It's vital that it is. Delegation is formally defined as transferring a defined task to a competent person with supervision, while you, the delegator, you retain that overall responsibility for the patient's entire care plan.
Okay, so the core safety checks are competence and clarity.
Exactly.
Let's use the ACIT framework to break this down, focusing on the 5 rights of delegation. It starts with assessing the tasks and the risk, right?
Yes. Assess the risk task. The urgency and the complexity, they dictate the level of competence and supervision that's needed. A high-risk task, say prescribing high-dose opioids, needs high competence and direct supervision.
Whereas a low-risk task, fetching a routine blood form, needs less.
Much less, yes.
Then the crucial step, choose a competent person. This is where scope creep can become a real problem.
It is a massive problem. You can only delegate within the recipient's documented and assessed scope. This is a common exam red flag. A healthcare assistant, an HCA, cannot perform specialized assessments or titrate high-risk IV infusions.
It seems obvious, but it happens.
It does. And if you delegate a complex discharge summary to an FY1 who has never seen the patient, you've chosen an incompetent person for that specific task, even though they're a registered doctor. The GMC expects you to check competence, not just assume it based on a job title.
Next, we loop back to structure. The E in ASI, explain with SBR.
Exactly. What is the task? Why does it matter? By when? What are the red flags? And how do they escalate back to you? Which leads to the IA, in-state supervision and escalation.
So you define the level direct, indirect.
Or available nearby. And you provide explicit, measurable thresholds to call you immediately. For instance, delegating routine bloods to a new starter. If you struggle with the 4th attempt, or if the patient gets distressed, stop immediately and call me. You define the limits.
And the final, non-negotiable step, the close the loop action.
That is the tie-off. You must require a check back.
So you get them to repeat the plan back to you.
Yes. Have them repeat the plan, the deadline, the escalation thresholds. This confirms you have a mutual understanding, which is a critical human factors safety check. And then you document it.
You have to document the plan and who owns it in the notes.
If you don't, the loop is open and accountability is completely lost.
Okay, let's run a quick delegation test case, something a bit more complex. I'm the medical registrar. It's 4 p.m. I need a complex, rapid discharge summary done for a patient going to a nursing home. It needs detailed DOAC instructions.
High risk.
I delegate this to my FY1, who is currently managing a patient with chest pain.
Okay, that is high-risk delegation. The task itself is complex, the recipient is busy, and probably doesn't know the patient's full journey. The risk is high.
So what's the correct, safe delegation there?
You use ACE, assess the risk. High medication error, discharge failure. Choose a competent person, actually multiple people. Delegate the review of the DOAC prescription to the pharmacist.
Ah, right. Use the MDT.
Yes, and delegate the factual summary writing to the FY1, but only after you've given them a full SBAR brief, that's the E, and you schedule a mandatory registrar review of the final summary, that's the I. The FY1 cannot safely own that entire discharge independently.
That competence check leads us straight to the wider multidisciplinary team, the MDT.
It does. Recognizing MDT roles is key to preventing delay. It's about knowing who to call. We use the WHOTO principle, using the right person at the right time.
And if we internalize these functions, we can prevent 2 big safety failures: delaying care by calling the wrong person or asking someone to do something outside their scope.
Exactly.
So who coordinates immediate ward logistics, staffing, priorities?
That is always the nurse in charge, NIC. They are the tactical coordinator. Staffing, ward priorities, managing bed flow, immediate bed space concerns. If you have 5 tasks and need help prioritizing, you have to involve the NIC.
Ignoring the NIC is a sign of poor teamwork.
It really is. You can't just unilaterally change the ward's priorities.
And the pharmacist's role is getting bigger, isn't it? It's not just dispensing.
Absolutely. The pharmacist is essential for polypharmacy, reviewing high-risk meds like anticoagulants, opioids, checking for interactions. Critically, they manage complex discharge counseling.
So if your patient is starting a DOAC,
Delaying pharmacy input for education and reconciliation is a safety failure. It could lead to life-threatening bleeding. They also manage things like IV to oral switches, which reduces infection risk.
okay, let's contrast the two key rehab roles, OT and physio, using different scenarios.
Good idea. Let's take 2 75-year-old patients who both had a fall. Scenario A. Patient A fell at home, has poor vision, uses a walker that's broken, can't manage the stairs or shower, and is worried about taking their 12 different pills. This is a functional and cognitive safety problem.
You call occupational therapy OT.
Right. They focus on function at home, equipment, cognitive screening for daily living, adapting the environment.
And scenario B.
Scenario B. Patient B fell but is now stable. They're struggling to walk more than 10 meters, have reduced muscle power, and need a structured exercise plan. This is a mobility and endurance problem.
You call physiotherapy.
Exactly. They focus on mobility, strength, exercise tolerance, and rehab planning.
That distinction is so important. And what about the part that dictates if discharge is even possible? The social worker or discharge planner?
Critical. The social worker or discharge planner manages community integration. They do capacity assessments for social care decisions, arrange funding, coordinate packages of care.
So if discharge is delayed because of funding or community resources?
The social worker is your mandatory contact. Delaying their involvement means patients stay in acute beds unnecessarily, which the GMC views as a failure to use resources effectively.
So if we go back to that frail 82-year-old scenario where a current falls 10 meds, living alone, stairs, pressured for discharge, the highest scoring answer is a coordinated response.
Precisely. It's a multi-factor problem needing a multi-role solution. You immediately request OT, physio, and pharmacy review. You tell the NIC to coordinate these assessments today, document the plan, and you do not confirm discharge until that safety assessment is complete and documented. That is the definition of safe practice.
Okay, let's move into acute crisis mode, section 3. This is where the stakes are highest, and these principles become time critical. The margin for error is basically zero.
What is?
And in an emergency, our sources say marks go to structure, not just speed.
That mindset is everything. Structure reduces chaos and maximizes efficiency when your cognitive load is just through the roof.
So what's the single most important first move in an arrest or an acute emergency?
Call early and allocate roles aloud. The single first leadership move is activating the system, calling 2222 or for senior help, and explicitly assigning roles out loud.
So you'd actually say,
You'd say, I'm team lead, Alice Airway, Ben Compressions, Chen Drugs, and DFib, Describe. This prevents that freelancing and hesitation that you see in a chaotic response.
and you have to demand closed-loop communication.
You must. Alice, administer 1 milligram of adrenaline. Stat. Alice, confirmed dose given. Alice replies, 1 milligram adrenaline confirmed given at 10.42.
So we establish the leader framework. Lead and call, establish roles, algorithms, dialogue, evaluate, record, escalate. The A for algorithm fidelity is crucial, isn't it? No improvising.
You absolutely cannot improvise. You have to follow the recognized guidelines. RCUK ALS, the sepsis bundles from NICE, and use NewW2 as the standard trigger. If a patient has a NewW2 of 9, that mandates immediate protocol-driven action.
You can't just wait for the shift lead to come back.
No. Ignoring algorithms or standard triggers is a critical safety failure.
The sources also highlight something called PACE-10, the short micro-huddle. What exactly happens in those 10 seconds?
The micro-huddle is a deliberate pause and plan. Every resuscitation cycle, usually every 2 minutes, the leader calls a 10-second stop.
And what are the questions you're asking?
It's PACE-E. Patient response is the rhythm changing. Access, do we have good IV or IO access? Ceilings of care, has the DNR status been confirmed? And escalation next steps, what bloods are pending? Should we call ICU now?
It's a structured pause to stop the team running on autopilot.
Exactly. It catches critical safety steps.
Let's talk about the trap answers here. Why does trying to fix a crashing patient alone score so poorly, even if you're incredibly fast?
Because it introduces unmanaged risk and it fails the principle of shared knowledge. If you silently run off to get fluids, the rest of the team doesn't know what you're doing. A patient in PEA arrest needs immediate coordinated effort based on the algorithm.
And you can't manage all the reversible causes in your head under pressure.
Your cognitive capacity is guaranteed to fail under that much pressure. You have to call for help, assign roles, and use the structure.
Okay, shifting to pediatrics now. The physiology is completely different.
Completely. The critical difference is that children arrest from hypoxia, not from primary cardiac events. So our priority has to shift fundamentally to ventilation first.
So what are the core pediatric rules? How does it contrast with adult ALS?
It's a sharp contrast. In pediatric life support, PLS, you must deliver the initial 5 rescue breaths before you start compressions if you're alone. The compression to ventilation ratio for 2 rescuers is 15:2.
So the focus is on oxygenation early.
Maximizing it. Failing to deliver those initial breaths is a major safety error.
And the cognitive load is much higher because of the huge weight differences.
Absolutely. Dosing has to be weight-based.
Yeah.
Everything. The standard approach is using length or weight tapes and local drug charts. It is non-negotiable.
So the trap answer, guess drug doses by eye, is a huge red flag.
A massive professional red flag. It signifies a very high risk of error.
And the trigger system for escalation in children.
We rely entirely on PUWS-led escalation. That's the Pediatric Early Warning System. National PUWS charts mandate early escalation to pediatric or ICU teams when thresholds are met.
So ignoring a high PUWS score is just like ignoring a high NWS2 score in an adult.
It is. It's explicitly cited as a critical safety failure, even if the child looks okay.
Let's take a specific pediatric scenario. An 18-month-old with suspected anaphylaxis after eating a peanut.
Okay. The anaphylaxis rule states that IM adrenaline must be given immediately per the age band, so 0.15 milligrams for this child. You have to avoid delay while you're waiting for IV access.
So the highest scoring action is giving the IM adrenaline right away.
Immediately, while you're calling 2222 and simultaneously getting a colleague to start securing IV access, delaying the IM adrenaline to get a cannula in is unsafe and scores very poorly.
And finally, parents. They're integral, but in a crisis they can interfere. How do you handle that safely?
You always involve them, but you do it with structure. During a crisis, assign a specific, calm staff member whose only job is to support and contain the parents, give them key factual updates, and keep them from interfering with the code team.
And document everything.
Everything. Document who was present and what information was shared. Structure saves children's lives.
Our final section, then, covers the interpersonal safety principles that underpin all of this. The GMC sources emphasize again and again that civility isn't a soft skill.
No, it's a tangible safety tool. Hostile behavior measurably harmed clinical performance. It's been proven.
So conflict is inevitable in high-pressure teams.
It's guaranteed. The goal isn't to eliminate disagreement. It's to handle it safely, professionally, and with respect.
Okay, let's take a scenario. I'm the medical FY2. I've told the cardiology registrar that their patient should be stepped down. The registrar confronts me loudly in the corridor, disagrees, and questions my judgment in front of everyone. What's the mandatory first step?
Containment and de-escalation. You use the PEACE framework. P stands for private space. Always relocate the conflict immediately away from patients. Let's step aside for 2 minutes.
Public arguing is a major pitfall.
It damages dignity, it destroys team culture, and it risks creating unsafe situations where patients lose trust or people just follow rank instead of safety.
So once you're in private, how do you shift from an emotional disagreement to a safe resolution?
You use the E to establish SBAR facts. You align immediately on the shared goal. We both want safe, timely care for Mr. K, and you use objective facts and protocols, the new WS score, a nice guideline, bed capacity issues, to find the real disagreement rather than focusing on blame.
In the A, C, and E.
Agree actions, owners, and times. The discussion has to result in a clear written plan that you both agree on and document. Call for support if the safety risk persists. Escalate to a consultant if you can't resolve it. And finally, enter notes, document a factual objective summary. No personal attacks.
Let's talk about the trap answers here, the ones that damage culture.
They almost universally involve either confrontation or avoidance. Options like, overrule loudly, I'm in charge, or send a long, critical email about the registrar's behavior.
Yeah, they score poorly.
Because they just escalate the heat, they ignore potentially valid risks, and they destroy psychological safety. The highest score is always that private, factual, patient-centered discussion designed for immediate resolution.
Okay, what about supporting colleagues under pressure? The GMC has a strong duty on this.
It does. We have to create supportive environments and act when colleagues are visibly strained, exhaustion, missing bleeps, whatever it is. Ignoring that strain is a patient safety issue.
So we need to stabilize this system, not just the person. Let's take that high-yield scenario. An FY1 is careful, we have sick patients, and a CT result just came through for a potential PE that the FY1 missed.
Right. You need immediate, safety-led leadership. First, scan and reprioritize. Call a short huddle, name the risks, we have a critical result in a distressed team member, and visibly prioritize the sickest patients.
And you have to take that critical result yourself.
Immediately, you action it. Do not delegate the most time-critical step back to the person who is already under distress.
Then you create capacity, which means raising the alarm.
Yes. Raise or escalate early. To the consultant, the site manager, you have to create breathing room. Delaying escalation to avoid bothering seniors or to let the FY1 handle it,
It's unsafe.
it results in harm. You're asking for system support, more staff, cover, clinical input.
And what about actually helping the distressed colleague?
That's the handle allocate part. You have to safely and privately remove them from the immediate pressure without damaging their dignity. Why don't we step into the tea room for 5 minutes? I'll take the bleep. You ask them about their welfare privately.
And then you redistribute the work.
You allocate tasks using SBAR briefs and checkbacks. The top action in that tearful FY1 scenario is always huddle, take the critical result yourself, call for help, and redistribute the tasks clearly. You fix the system failure before you address the individual's emotional state.
Finally, let's look at safe supervision. This is dynamic, it's essential for safety and for junior development.
And it's all about risk-matched oversight. The framework here is guide. You grade the supervision direct, indirect, observed based on the task risk and the supervisee's skill.
So you have to understand their competence.
You understand their competence, ask them what they've done before. A novice doing a first lumbar puncture at 2 a.m., even if they're technically signed off, probably requires direct oversight or just scheduling it for a safer time. Risk dictates the supervision level.
And the briefing has to be meticulous.
You instruct via SBAR and you set explicit thresholds. This is the safety net. If the patient becomes agitated, or if you can't get the sample on the second attempt, call me immediately. Do not proceed without me.
Which brings us to availability. The supervisor has to be reachable.
That's the core of the ABLE mnemonic. Available, boundaries, learning, and evidence. The supervisor has to be reachable by bleep or phone. If you're not contactable, supervision fails and patient risk skyrockets.
And you have to document it all.
Yes. Enter notes and review. All instructions, thresholds, review times must be in the patient record. That documentation closes the supervision loop.
And one crucial reminder on accountability here. The supervisor retains overall responsibility for the patient's plan.
That is the ultimate safety check. If you delegate a complex procedure, you have to be satisfied that the task and the supervision were appropriate. If the delegate makes an error, you are accountable for the system that allowed that failure. Your signature on the plan means you own the outcome.
We've covered a huge amount of ground today, translating those, well, quite broad GMC duties into structured score-maximizing clinical actions.
And actions that protect the patient and your professional license. We detailed how safety is built on clarity, not charisma, anchored in SBAR and accountability through PAC-CTTC.
We explored safe delegation with the ACEIT framework and the vital role of the MDT using the WHO2 map.
Emphasizing that using the wrong person, even for a simple task, is a safety failure.
Absolutely. Then we covered high-risk environments, using leader and pace 10 for a dose to ensure structure over speed, and for children, emphasizing ventilation first, weight-based dosing, and ABCP-WS escalation.
And finally, those essential skills. Handling conflict professionally with peace and supporting colleagues using SHARE to make sure capacity is created safely.
So to synthesize this entire deep dive into 3 absolutely high-yield takeaways that should guide your mindset in the exam and on the ward.
Okay, number 1, clarity mandates action. Always use SBR, name owners for every single task, and set explicit, measurable deadlines. Ambiguity is always unsafe.
2, escalation is capacity. When capacity or safety is at risk, a high NUWS or PUWS score, team distress, call your senior site manager or ICU immediately. Waiting or hoping you can manage it alone is the low-scoring, clinically unsafe option.
And 3, document accountability. Record your decisions, the named owners, the timeframes, and the escalation thresholds. If it's not written down, it didn't happen safely or professionally.
The GMC standards and the frameworks we've reviewed today, SBR, PAC-TIT, ACIT, They aren't just rules for an exam, are they? They are the fundamental clinical safety algorithms designed to counteract human factors when we're all under pressure.
They really are.
So the final thought is this. How might applying these structured communication rules proactively in your least busy moments prepare you for when the system inevitably breaks and clarity is needed most?
That's the key. We really encourage you to turn this knowledge into automated practice. It'll mean better scores and much safer shifts. And you can find more targeted practice materials focused on these frameworks at PASMSRA.com.
Thank you for joining us on The Deep Dive. We'll catch you next time.